And if somebody ever asks me, for the vast majority of what I do I have to have surgery? The answer is no. For most orthopedic sports medicine injuries, you never have to have surgery. I think the follow-up for me is, well, what's the consequence of not having surgery?
Welcome to the Motion Lab, the podcast that explores the science of movement and helps you live a stronger and healthier life. Welcome back to the Motion Lab podcast. My name's Chuck Dowell. I'm one of the physician assistants here. I'm here with Dr. Yager.
Hi, I'm Craig Yager, one of the sports medicine fellowship trained surgeons here at the Colorado Springs Orthopaedic Group. I did my sports medicine fellowship down in San Diego, where we took care of some of the teams down there. And I've been with CSOG for the last 3.5, almost 4 years.
So this episode, we're going to focus on ACLs and ACL reconstructions and kind of all aspect of ACLs. You treat and or see ACL tears on a daily basis, correct?
Yep, that's correct.
It's interesting. We just did a recent podcast and we talked about how the ski season, almost one of our busiest seasons for ACL reconstructions, because of that lever arm of the ski oftentimes causes ACL tears. We normally think fall sports is a common time, but the ski season is also a very common time.
Keeps us busy year round. So, women's soccer is another common sport that we see a lot of ACL injuries. Around here, skiing is such a common activity for people of all ages. We're not just talking about younger athletes, we're talking about all people. That's why it becomes such a common mechanism of injury. But we also see it with football players, we see it in basketball, really any activity, sometimes even stuff around the house can cause people to tear their ACLs.
So when you see a patient in clinic and you're kind of breaking down for them, I think you tore your ACL. How do you discuss that with the patient? How do you explain what the ACL is, the function of the ACL in the knee?
So the ACL is one of 4 ligaments in the knee, one of the 4 main primary ligaments in the knee. And the function of the ACL, which stands for the anterior cruciate ligament, it lives in the central portion of the knee and it prevents the tibia from sliding too far forward. The one thing that's a little bit different about the ACL is that it has a substantial amount of rotational stability to it. So oftentimes you can kind of describe the mechanism of the ligament by either illustrating on their physical exam what feels loose or what feels lax, or how it's commonly torn. So one of the more common mechanisms of injury is the non-contact knee injury. So if you're watching sports and you see this, or if it happens to you, hopefully not, a lot of times it's a non-contact injury where you're twisting or pivoting or quickly changing directions and your body is rotating around your knee. In that scenario, if the ACL tears, the tibia essentially keeps sliding forward, and that's what causes the instability type mechanism. And it's also a good illustration of what the ACL does. So I think that helps them kind of wrap their mind about what it is, why it's there, why it's important to have it, and then also why it tore.
And so we briefly mentioned skiing is a big risk factor for ACL tears, and that's mainly because of the lever arm of the ski. What would the risk factors be as far as just an athlete or the general population? As we mentioned sports specific, but what other risk factors could we discuss?
Yeah, so outside of physically playing sports, for most people, if you don't play sports, you're probably not going to tear your ACL, or if you don't ski. But there are some anatomical reasons for why this might happen. The groove that the ACL rides in, which is called the notch, it's a kind of an area of the femur that for some people is quite wide, for some people is quite narrow. The narrower that notch, the more likely you are to tear your ACL. Tibial slope, or how much bend the backside of your tibia has, is also a risk factor that causes the tibia to want to slide forward, which in that same injury mechanism is what leads to the ACL tear. So you're not hitting that end stop, it just keeps going. So those, and I do think certain people, especially if you're trying to recover from an injury, if you have any muscular weakness, we focus on ligaments, which are static stabilizers of the knee, meaning they don't stretch, they don't move a whole lot. But your dynamic stabilizers are also super important, primarily your quadricep. So if your quad is weak from any other injury or just deconditioned from not being in good shape when you're playing your sport, those can also be risk factors for injury of the ACL specifically.
Yeah, so as you said, there's the non-modifiable. We can't change your anatomy. So unfortunately, we're born with potentially that notch being too narrow or that tibial slope being off. But the modifiable risk factors, if somebody comes in and says, how can I prevent myself from getting an ACL tear? are those muscular imbalances, right? So, if they have improper firing of their quadriceps compared to their hamstrings, those are things that are potentially modifiable that we can help, correct?
Yes, and they've studied this pretty extensively, and a lot of it's in women. But the neuromuscular training is what we kind of the term that we would use to describe it. Sometimes you can think of it as jump training or plyometric training, where you're kind of teaching people how to fall is another important aspect of this. Doing box jumps and falling from box jumps and making sure that the knee anatomy and the alignment when you're falling is the way it's supposed to be has been proven to be successful. It's just super labor intensive. It requires a lot of effort, it requires a lot of specialized training, and it requires a lot of time to keep up with those exercises and those activities. So, because you might follow that question up with, if we can prevent it, how come we see all these high-level female soccer players that have ACL after ACL after ACL? Some of it, even in the best hands with the best trainers and the best rehab, there's only so much you can do.
Yeah.
And you can still tear it no matter what. But there are some things that can help lower that risk, at least to some degree.
Yeah, and we talked about there during the skiing episode that sometimes if you fall kind of in certain directions, you'll reduce the rotational force across your knee. And that's kind of a similar concept as you're discussing. We teach people how to land or how to fall. And if you land appropriately with your knees in the proper positions, it'll reduce that rotational stress to your knee and potentially can prevent the injury from happening. But as you said, we talked about before we were kind of starting the episode, some things are not preventable. Sometimes turf, can cause these types of things. Weather can sometimes cause it. Sometimes hot days will cause a more sticky environment, or rainy days will cause you to slip. And those are things you can't necessarily adjust or prevent. So if somebody comes in and has a concern for an ACL tear, what are the more common symptoms you see in those patients?
So the classic presentation for an acute ACL injury, meaning one that just happened or happened within the last week or so, is a very swollen knee. These things tend to be very vascular, the ligament itself. So when it tears, there's bleeding within the knee joint. The bleeding within the knee joint causes swelling within the knee, which causes some difficulty with range of motion. It can be difficult to assess laxity to the ligament or how loose the ligament is at the time of their evaluation because it's so swollen. But there's only a handful of things that typically will cause an acute knee effusion like that are related to an injury or a trauma. And the ACL is probably number one or two of the things that can happen for that. So if you show up in my office playing a sport, have a non-contact injury with a swollen knee, ACL is going to be at the top of my list.
Yeah, and then I think maybe some pain with weight bearing, right? A lot of the times for 7 to 10 days, it'll hurt to walk on. I think lack of inability to get the knee straight because of those bone bruises that happen with that pivot shift is something we often see as well. So those are all concerning kind of symptoms of somebody that has it. And as you said, sometimes that guarding kind of prevents us from doing the test, but ultimately imaging is going to be the next option to evaluate for it, correct?
Yeah, the gold standard for diagnostics is an MRI. And an MRI is usually pretty conclusive for ACL tears. The other thing that's important to note about ACL tears when they happen, 98% of the time, it's a complete tear.
Yeah.
These things tend to tear right at their mid-substance. There are subsets of tears that can be avulsion injuries that happen on either side of the bone, but the majority of them happen to be mid-substance tears, which does kind of create that dramatic presentation with the swelling. The swelling does subside, and acutely you'll have some pain with weight bearing, you'll have pain with range of motion and limitations with range of motion, but a lot of times the pain will often improve as the effusion comes away, which can lead some people to this sort of false sense of security that everything's okay. They may say, give it some time, they give it a week or two, the swelling comes down, and they think, okay, my knee's fine. But what will persist and really come to the forefront in that situation is the instability. And that's when they'll notice if they're changing directions that the knee still wants to give way, they can't trust it. Even in simple activities of daily living, I always use the example of you're trying to leave your house and you forget your keys, so you quickly try to pivot, and then you just feel your knee give out on you.
Yeah. I was just going to say, it's interesting the variety of presentations we get, because I've had a lot of patients who come in like that. They walk in fairly, normally, not a significant limp, not a huge swelling inside their knee. And you kind of think, hey, this doesn't seem like the normal presentation of the ACL, but obviously we all respond to injuries differently. And some of those patients have a very limited, response to the injury and can get that false sense of hope We don't use the ACL during straightforward activities. I've had patients that can jog and do fairly comfortable, but as soon as you said, they try to they try to pivot or turn a corner. Oh, I have to edit that one out. As soon as they try to pivot or turn a corner, they start to notice that instability sensation.
Yeah, even outside running. I mean, around here, trail running is a really popular sport in the summertime, and that can be really difficult for people that are ACL deficient. But even running outside, yes, maybe you're fine in a straight line, but if a car's coming or you got to stop or you need to quickly get out of the way of someone, those are the times that you'll notice instability. If you pay attention to the number of times you twist or pivot on your knee on a daily basis, even if you're not participating in a support, it will surprise you, the number of opportunities, so to speak, for instability.
So we briefly mentioned the neuromuscular training. So there's a lot of programs out there that advocate this, and there's a lot of ACL prevention programs. We go to some of the local sports and try to do those programs. What are your thoughts on those programs? What are the statistics show as far as do they help to prevent things, and how could listeners kind of either get online resources to that, or what's your recommendations there?
I think if you can find a good program that you trust and you feel consistent with, you have very little to lose. If you can stay consistent with the exercises and it can become kind of part of your warm-up routine and your kind of daily exercise regimen, I think it's a great option, especially for younger patients where if the growth plates are still open and we really want to try to protect the ligament as much as we can, we're still developing the muscular strength, we're still developing some of those more dynamic stabilizers. I think those programs are wonderful if you can find a good one to do.
Yeah, I think it's interesting. I always use the example of as myself, I was a tall, clumsy kid, and I think my neuromuscular control was very poor, and it took a long time for me to kind of grow into my body and learn that neuromuscular control. And I got my kids into gymnastics, and their ability to control is much better than mine. And I always wish I had done gymnastics when I was young, just for that reason. So I think, younger kids, if they can get into those multiple sports and learn that neuromuscular control, that'll help prevent injury a lot.
Strength training is another classic example of, for years, it was kind of frowned upon in younger adolescents. Yeah. But what we're learning is that strength training in younger kids, it doesn't make them bulky and strong, it gives them neuromuscular control. Yeah. It allows them to identify where their limbs are in space and develops their coordination more than anything else. And I think from an injury prevention standpoint, like you said, that's probably the most important thing that we can do. As you get older and as your muscles develop, growth plates close, you become more comfortable with your body and how you move and how you function. It probably becomes less important at that point. But there's no amount of plyometric training and things like that that's bad.
Yeah, and we talked about in the episode we just released in the youth athletics about how important multiplanar sports are when you're young to learn that neuromuscular control. Some injuries happen because of single planar sports. You're a year-round baseball athlete and you kind of don't have that control to do cutting, pivoting, twisting activities. And so it's so important to do that when you're young. As far as an ACL tear, does it have to be fixed? Like, what's your conversation when somebody comes in and says, do I have to have surgery?
I think my conversation, if somebody ever asks me, for the vast majority of what I do I have to have surgery? The answer is no. Mm-hmm. For most orthopedic sports medicine injuries, you never have to have surgery. I think the follow-up for me is, well, what's the consequence of not having surgery?
Correct.
So the question then is, if we kind of shift to that mindset, well, what happens if you don't fix it? How often are you unstable? Mm-hmm. Does this happen to you on a daily basis? What activities do you like to do? Do you want to ski? Do you want to do trail running? Are you unstable, even if you don't want to do the sports? Are you unstable in your daily life? Are you unstable around the house when you're cleaning or vacuuming or whatever? The number of people that will describe instability episodes or incidences purely doing normal activities of daily living is very high. So I think in those people, we start to talk about, what are your goals? What do you want to do? What do you want to do for your life moving forward? And if instability is a limiting factor, then we start talking about surgery for the ACL. But no, you certainly don't have to fix it. I've had people where we've tried not to fix it, even in older patients, and they've come back and said, you know what, I'm still unstable, and I want to have it done.
Yeah, it's pretty rare, I feel like, that you can get away with not having an ACL. Some people have inherent stability. One of the orthopedic surgeons I worked with before, kind of my mentor I worked with for a long time, he tore his ACL when he was young and never had it fixed. And he could play hockey, he could ski, he could do everything on it, and he had no instability episodes, but he had that natural inherent stability, probably didn't have that posterior slope. He kind of had all the anatomical risk factors, didn't have any anatomical risk factors, and so that's probably why he did so well. But that's a very small subgroup.
Yeah, and he probably had really strong quadriceps, and I think you can make up for a lot with strength. And we talk about that relationship in clinic all the time between instability and strength. So, and how do you use those two things and kind of work at odds to one another? So the more unstable you are, the stronger I want you to become, because it helps hold those joints stable and really focuses on those dynamic stabilizers.
Right, and that comes into play a lot in the shoulder too, right? Because the dynamic stabilizers are so important, and we can train those dynamic stabilizers. That's a modifiable, thing we can train. The static stabilizers we can't fix, and so if we've stretched out those ligaments, sometimes those dynamic stabilizers can provide enough stability where they can do well. What are the latest advancements as far as ACL repairs? What have you seen over the last few years as far as how we fix them and what the new generation is?
I think, we've been definitely developing our soft tissue graft constructs for years, and I would probably say it's still technically the gold standard today is a bone patellar tendon bone graft, where we harvest a piece of bone from the kneecap and a piece of bone from the tibia and use that to rebuild or reconstruct a new ligament. The downside of that type of a procedure is that because you're harvesting that bone, it does lead to a weak spot within the patella, which can cause fracture. And it also can cause continued pain at that harvest site really forever. So some people will continue to report difficulty with kneeling on it. They'll have pain over that anterior aspect of the knee. So we've done soft tissue grafts for a long time as well, primarily using the hamstring tendon. And there's been plenty of people that have had phenomenal results with that type of a procedure as well. Recently, we've been utilizing the quadriceps tendon graft a lot more. It's a thick, robust graft, which has a lot more strength and resists stretching that the hamstring sometimes happens. But it doesn't involve harvesting bone like the bone patellar tendon bone graft does. So to me, it's kind of the best of both worlds. But I think what's really differentiated the quadriceps, because it's been used in the past as well, is the fixation constructs that we're using now. So tensionable loop fixation, which really just means that we use buttons that sit on the outside of the bone, and we have looped suture that we can tighten inside surgery. So we can really dial in the tightness of the ligament as much as we possibly can to keep it from stretching over time and becoming loose or lax. I also think our optics are improving too. So intraoperatively, our ability to see with 4K monitors and smaller cameras and making sure that our tunnel positioning and tunnel placement is anatomic. We know that inappropriately placed tunnels are some of the higher causes or reasons for why reconstructed ACLs will fail or re-tear. So we want to be really critical with where we place our grafts. So I do think that's helped a lot as well.
Yeah, because as you talked about, we've learned over time that not only does it have that anterior translational stability, but it also has that rotor, stability. And sometimes it's hard to get both of those with just one single tunnel placement. So there's some modified procedures we can do, right? There's the LET procedure, which we could potentially do. What are the concepts regarding that?
So you're talking about the lateral extra-articular tenodesis. So that's a really important I think especially in a revision setting or people that may have some risk factors, say you have an increased slope, it's a very hard problem to fix. You can cut the entire tibia and change the orientation of the slope, but it's a lot of surgery to do that. So we can do things like, I think number one thing that we've done to really try to improve the rotational stability of the ACL is what's called independent tunnel drilling. Yeah. So the old techniques, which was kind of what you're referring to, are the transtibial drilling, where we basically take one drill and we run it all the way up the tibia and into the femur. We've really gone away from that. So we want to drill the tunnels independently so they're divergent. So you don't end up in a situation where the tunnel runs straight up and down. The tunnel should be at angles to one another. So I think that's step one. And we can do that relatively easily at a primary setting, so a first-time ACL surgery. If we do identify some risk factors for re-tear, then we can add the extra-articular tenodesis, which is basically taking about a centimeter strip of the iliotibial band, and we route that under the lateral collateral ligament and fixate it on the femur. And what that's been shown to do is really change the rotational component of the tibia to help hold it tighter. So as you're kind of moving into an extension, it will keep that tibia from subluxating forward. So it acts as kind of a restraint from some of the more common things that can cause re-tears of ACLs.
A little bit of a check rein, kind of a belt and suspenders. Right?
That's exactly right.
So let's say I come in, I have my ACL torn, I'm going to get the reconstruction. The next logical question is, okay, what's the recovery? What's your recovery after an ACL? What do you tell the athletes or the patient as far as the expectations?
The first thing I usually tell them is kind of go through the day of surgery itself. So typically for me, most of these are done in our outpatient surgery center, and it's typically an outpatient surgery. So we're talking about, I usually tell them about an hour of surgery. Some of that depends on what else we find. It's not uncommon to find meniscus tears at the same time as an ACL. And sometimes an MRI doesn't catch those. So I think it's super important that we're checking the meniscus at the time of surgery and doing a full diagnostic exam and dealing with what needs to be dealt with while we're there. So surgery, assume surgery's done, all arthroscopic, little poke holes in the knee, a harvest site for the graft, which isn't terribly big of an incision, something about like that. Once that's all done, you're in recovery for an hour or so. For mine, let's assume that the meniscus was intact. I allow weight bearing as tolerated right away. We typically will do a nerve block day of surgery, which does make it somewhat difficult to ambulate. So most of them are locked in extension at least for a day or two. But once that block wears off and they start to feel more comfortable, I let them move as much as they want, range of motion as tolerated, and then ambulation as tolerated. For the first 2 weeks, I ask that they sleep with their brace locked straight to really focus on the extension piece. It's the hardest motion to get back, and we want to get that back as soon as we possibly can. So really focusing on that, and then beginning physical therapy within a week of surgery is also critical for your outcomes. Establishing the relationship, making sure that you're doing the exercises, and making sure that we're getting started right away. So brace use in total is about 6 weeks for me. I tend to think that the quadriceps, which becomes weak from either the graft harvest or just from the surgery itself, takes about closer to 3 months before it's really functioning and firing well. And most people by 3 months post-op are doing most activities of daily living without a whole lot of difficulty. I like to continue physical therapy, focusing on continued quadricep strengthening up until about 6 months after surgery for everyone if we can make it happen. It takes about 6 months for that graft to fully heal or incorporate into the bone. Once the graft is healed, we can start to work on a little bit more lateral motion activities, kind of more of the twisting, pivoting, cutting in physical therapy with a goal of returning to sport at 9 months. And there's really two factors for me as far as return to sport. It needs to be 9 months at a minimum. There have been studies shown that athletes that return at 6 months have a super high re-tear rate, as high as 25%. If we can wait until 9 months and we're using your own tissue, then that re-tear rate may fall to 6 to 7%. So substantial reduction in risk of re-tear. And then at 9 months, I also want your quadricep strength to be ideally 90-95% of the other side. The stronger, the better. That's when I'll say it's okay for you to go back with your brace for that first full year.
And that's something that they can evaluate in physical therapy, right?
They can. There's objective ways to do that. There are machines that can measure the strength, and you can compare side to side. A lot of athletes know. They have a pretty good feel. My quad's still a little bit weak. When I'm doing squats and exercises, I can tell that I'm not quite focusing on that side as much. The other side's taking over. So we do a lot of single leg work in rehab too, single leg press, things like that can really try to focus on really building the strength in the operative leg.
Yeah, it's interesting. The rehab really focuses on the neuromuscular stuff, which we actually do for ACL prevention as well. And I've had some athletes come out of the rehab process better athletes than they went going in because they had better neuromuscular control, they had better strength, they were quicker and faster, so that rehab process is so important as far as the recovery. And as you mentioned, it's not just the time, it's also knowing that you have the strength, no strength deficits to be able to return.
Yeah, it's both components. And I think if you don't have them, your risk is higher that you're going to have some sort of complication when you do go back to sport.
Yeah, every athlete wants to get back to sports as soon as possible. And it's like kind of like the Jerry Rice, right? He returned at 5 months after tearing his ACL and unfortunately tore it again because we knew that the graft wasn't necessarily incorporated at that point. But they thought his dynamic stabilizers were strong enough to allow him to return, but that's only one part of the equation, unfortunately. One of the biggest things, and probably a lot of research has gone into this recently, is the mental aspect of injuries. A lot of athletes, their identity is their sport. And if they injure themselves and they have to miss some certain time, there's a large mental component to it as well. What's your process as far as that, from the injury itself and the return to athletics as well?
I think it's probably the hardest barrier for a lot of people. I really do. I think when it comes down to it, you've put in so much time, you've put in so much effort, the daily exercises, the, 30 to 40 physical therapy visits or more for some people. And then I finally say, okay, go play. And you're like, well, wait, what? So I think overcoming that hurdle is really the last barrier. It's a big reason why I use bracing. There's no study that says that a brace will prevent you from tearing your ACL, but I like to use it to kind of help overcome that final hurdle. Yeah. I think a lot of athletes will think of that brace as sort of a small insurance policy as they're continuing to develop their strength. They're easy to play in, they're relatively straightforward to use, and I think it just gives you that last little bit of help as you're continuing to develop the strength that you need to play in these games too. Because there's no amount of weightlifting or strength training that really truly prepares you for, live action football or soccer or basketball or whatever your sport is. It takes time to get that strength back and to become kind of game fit again. So I think the brace just helps make that transition, helps people overcome that mental hurdle.
Yeah, and unfortunately, no matter how much physical therapy you do, cutting, pivoting, exercise you do, there's nothing like actually playing in the game. And so, as you mentioned, before we started, sometimes there's some hesitation initially going back to playing, and that first part of the season or first season is always not quite as good as they would like it to be until they build up that confidence to be able to play at full speed.
They need to be able to forget about it.
Yeah.
You need to be able to play the game without thinking about it. And that's part of playing injured, and any athlete's played injured to some degree. And you know how hard that is when you're worried about your injury to also fulfill your role in the team. So moving past the I'm still recovering to I'm recovered and can play at the same level of speed and ability that I played before, it's a time thing. And you see it in pro athletes all the time. If you watch people that are recovering from a torn ACL when they come back to their professional sport, they're not the same athlete for several games to even several months until they've really learned to trust their reconstructed knee.
Yeah. Well, I appreciate your time today. Thank you I know you got a busy day, but thank you for sitting down and talking about ACLs with us. So if somebody has a concern for an ACL injury, how can they get a hold of you? How can they get in to see you?
Call our office, ask for me directly. I'm happy to get people in to be seen as quickly as we can. Obviously, these are traumatic injuries, so the quicker you can get some answers, the easier it is for you and for your family. So.
Yeah. And then I'm part of the Express Care, so that's a walk-in clinic. So if you're having trouble getting a hold of Dr. Yager's office, you can come in and see us. We can get you set up for the MRI and get him to see you for the follow-up, and you can kind of take things from there.
That sounds great.
Beautiful. Well, thank you for your time. I appreciate it.
Happy to help.